Muy buenas tardes. Estamos ya en la sesión 2 de ARI23, que pertenece al área primera, que versa sobre actualidades en optometría y técnicas de estudio del ojo. Tenemos una interesantísima sesión actual ahora mismo sobre actualidades en estudio clínico del ojo y de la visión, que va a ser atendida por muy distinguidos invitados, entre los cuales vamos a destacar sobre todo los dos keynotes de los doctores Ruiz y además Ansulín, que nos van a abrir la sesión con unas interesantísimas keynote sobre temas de máxima actualidad en el estudio clínico del ojo y de la visión. Por tanto, vamos a comenzar ya con el doctor Félix Ruiz de Madrid, que nos va a hablar sobre la actualización en la OCT de segmento anterior de nueva generación. Tiene la palabra, Félix.
Good evening. I'm going to try to do an updating of the new generation of anterior segment OCT. This is my disclosure. I am clinical consultant and researcher for Tomei. And I want to start my presentation with this sentence. Anterior segment OCT represents a revolution in the assessment of the anterior segment and will become an essential tool in the ophthalmic surgeon's office. The anterior segment OCT is an integrated device for diagnosis and pre- and post-operative assessment of the anterior segment. We can address the cornea, the anterior segment, the crystalline lens, and even the glaucoma. But for the question of time, we will focus in the anterior segment and the crystalline lens. Currently, we have two anterior segment OCT sweep sources in the market, but we will develop my talk about the Cassia 2 Tomei. I have the experience in the last 5 years. The Cassia 2 is a multifunctional device. It allows a high-quality 3D image with a scanning laser of a wavelength of 1,310 nanometers. And due to its wide and scanning depth, it allows the entire morphology of the crystal lens to be analyzed. And also with the video function that we have been working with Tomei, allows a dynamic measurement for the anterior segment in relation to ambient light condition or even the accommodation changes. Going into the crystalline lens surgery instead of intraocular lenses, we have this preoperative assessment in the pre-op cataract mode, and we can see the corneal map and the lens biometry. Corneal map, it allows automatic quantitative analysis to every structural angle, just in temporal and nasal, and 3D or just in plane, in one plane. And also it allows a lot of parameters of the anterior segment. All of them are automatically. And also we can measure any area of the cornea, delimiting the length of the distance of the center of the cornea, for example, this flap, or also this scar, or this is intrastromal corneal ring that we can then limit the depth and the distance from the uppers. The Cassia 2 is a sophisticated OCT-based corneal tomograph. So we have these maps that are very similar. We are used with the same field. For example, we have also an ectasia screening. And in the last updating, we have the epithelial corneal topography. In the lens biometry analysis, we can make an estimation of the crystalline lens equatorial plane. We can make an analysis of the morphology of the teal in the center of the crystalline lens, just in 3 dimensions or in 2 dimensions. Different images of cataracts, just explored with the lens biometry. Examples of a polar posterior cataract and a subcapsular posterior cataract. A very challenging case with a very narrow angle, so we can estimate how is the anterior segment just before the surgery. Measurement of pupil size in order to take a decision of the type of IOL to be implanted, or even to perform a flax or not in very small pupils. This device allows measurements to be taken in some complex situations, such as this case of nystagmus, where it would be impossible for other devices. Continuing with the crystalline lens surgery analysis, we have in the pre-op cataract, we can address the calculation of the IOL in 3 different screens. In the first spread, we have an IOL screening. We have all the parameters we need just to make a calculation of the IOL. We can observe as well the tilt and the dispersion of the crystalline lens. We know that there are a strong correlation between both parameters and pre and post-operatively. In the old calculation screen, we have available different formulas for different lenses. Currently, we have to introduce manually the axial lens in the device, but not in the anterior from header. And with historic IOL screen, we can choose the selection of the core IOL. We introduce the astigmatism induced for the surgeons and the tissue axis manually, and then we will have the cylinder power and the axis register. For the postoperative assessment, we have this marvelous screen. We can check the pre-op and the post-op situations, and we check the tilt and the centration. We can compare the induced astigmatism, and also we have checked the EL torus axis. And in the last actualization in the CASIA 2 Advanced, we have the marking points of the toric axis on the implanted EL, so we can observe directly, and we can measure the real axis of implantation of the toric IOL. One example of the tilt and the centration of an IOL, and here this is a tilted lens in a patient complaining of bad quality of vision. We can observe also in the OCT the change for the temperature of the hydrophilic IOLs, just 15 minutes after the implantation, and in the checkup in the afternoon 4 hours later. A PCR and an Acrosoft with a glistening, and after the capsulotomy with laser jack. Two lenses in piggyback for the treatment of negative dysphotopsia. This is a horizontal and vertical image. A nice recently case is the lady complaining of myopic shift and blurry visions, and this is the lactocrumenasia after the neodymium laser jack capsulotomy. You can see very well even the posterior capsular rolling. And finally, a white catheter with tension subcapsular fluid, and this is after neodymium jack laser impact on the anterior capsula just before catheter surgeries, trying to avoid the Argentinian flag. Moving on to the focal lenses, we can measurement a lot of geometry parameters for the PL calculation. We have available just in one click the anterior segment measures just for the PL calculation. Within all the measurements we can get, I want to highlight the crystalline lens rise measurements. Here you have two candidates for ICL. In the left side you have a very negative, very flat crystalline lens rise, but in the other side is the opposite thing. It is very positive. So it's very important in the calculation of the size for the ICL. Automatically we will obtain all these trabecular iris angle measures. We will focus in the trabecular iris angle, very important in the measurements in the focal lenses. In this screen you will see the iris angle measures, just pre-op and post-op. This is, for example, the trabecular iris angle pre and post-op. This is the AOD just before the surgery, after the surgery. You have here the angle recess area after the surgery, and here just before the surgery the trabecular iris space area, and this after the surgery. Even in very difficult cases like this nystagmus, we can obtain all the measurements we need to analyze the focal lens inside the eye. For the ICL sizing formula, we have integrated in this application two formulas, the Nakamura formula and the Kemiya-Shimizu formula, that both are publicized. Other function that distinguishes the CASIA 2 is the ability to dynamic analysis of anterior segment in the ball and the facet IOLs. In 2011, we introduced the dynamic ball concept with the ball range like a paradigm shift in the ball assessment. With those two parameters, the ball interval and the ball range, we defined the movement of the ball and the focal lenses inside the eye with the change on the ambient light conditions. In this screen, you can see the dynamics of the vault of different facet posterior chamber IOLs. The video application post-op ICL is now integrated in the Cassia 2 software, so we can now do a dynamic analysis of anterior segment structures based on external ambient light conditions. You can see here that the enormous ball range it has in this case. To finish with the Cassia 2, we can relate POs to the structures of the anterior segment, the concept I have called relativism of vault. This is a very good example of a hyperope ICL about the dynamism of the vault. You can see here how the lens is moving inside the eye with the changing light conditions, but also it's an example of the relativism of vault. You can see here, this is the vault range, is very, very high, 469 macrons, but also the vault interval is 1000. This is endoscopic, but if you see the crystalline length rise and you see the angles, it's a good moment. So we can leave the lens here, but we cannot leave this lens because you have very narrow angles. You can see here, and that we have to exchange. But in the other cases, you have a very high vault. It's more than 1,300, but in this eye, the crystalline lens rise is really flat. So that's the reason, because the dynamic of the vault and the angles are quite fine, and we can leave this lens here even when more than 1,300 microns endoscopic conditions. Another example of the dynamism of the vault, this is one eye that had to be explanted because the patient was complaining about halos and the pupil was different between eyes because the second eyes are implanted with 12.6. Please look how different is the dimension of the vault just before the ICL exchange and after the ICL exchange of a lower size. And what will come in the future? Now we have integrated in the Cassia 2 the ability of make a simulation with the anterior chamber facet IOLs, but not yet with the posterior chamber facet IOLs. Maybe in future, with artificial intelligence, we will be able to make a simulation and even to calculate the ICL size with the artificial intelligence. Right in this moment, I leave you with this sentence from Peter Drucker, a very famous economist of the 20th century. I think with this kind of device, we are in the path to create a new future in the ophthalmology. Thank you so much for your attention, and I open for any question you can translate to me.
Muchas gracias, Félix, por esta excelente presentación que ya nos adelanta un poco cómo va a ser el futuro, las nuevas tecnologías y lo que nos espera. Pero vamos a continuar con estos nuevos avances con la segunda keynote, que se titula Inteligencia Artificial, Robótica, Agentes Virtuales, la nueva búsqueda de la inteligencia médica, a cargo de Michel Achoulin, que nos va a hablar de todo esto en un solo dispositivo. Adelante.
Hello, everyone. Many thanks to Dr. Alio to have invited me to share with you our work on this new quest for medical intelligence based on virtual agents, robotics, and AI. In the past, medical intelligence was mostly based on experience. Today, it is based on the communication of expertise between doctors, both in meetings and journals. But in the future, we predict that medical intelligence will be mostly based on data sciences that will make a good use of the data collected by the machines. This is the reason why we have developed this revolutionary multimodal diagnostic system we call Área suite where we use both a virtual agent to collect subjective data that includes risk factors and symptoms, and also visual tests taken online by patients, but also objective data that we acquire in less than 5 to 6 minutes with a robotic station, and also AI-powered analytics based on a collection of artificial intelligence algorithms. The conjunction of subjective and objective data makes it possible to build up this medical intelligence that patients and doctors need. This is a demonstration of our chatbot. The chatbot uses an online session to collect results from visual tests taken by the patient, and also to collect all the risk factors and symptoms based on smart questionnaires, which uses a probabilistic engine to choose between 600 questions to be asked to the patients based on the previous patient's answer. Typically, we need 12 to 20 questions to determine the most probable diagnostics in a bank of 120 conditions of the eye. So you see that the next step will be for the patients to come to the eye center, and there the patient is shown to the station. The station works as a full auto process that fits all morphology from the children to the very tall people. It is both guided in any language you want, and of course, it's telemedicine ready. This station is able to process patients in a sitting or standing position, and it acquires about 100 parameters that includes all the data that the ophthalmologist needs to make a decision about the patient. All the subjective and objective data are synthesized in this comprehensive eye health report. We call it a smart vision report. In the first page, you see that we have all the questions that the patient has been asked to arrive to the 3 most probable diagnostic in the bottom of the page, and that's only based on subjective data. And the next pages are about the ocular surface, the anterior segment, and the posterior segment. We use a number of algorithms based on AI or decision-making tools to predict nearly everything about the patient. That includes the prediction of the diagnostic based on the chatbot, the prediction of subjective refraction, the keratoconus screening, the power calculation of the intraocular lens, the detection of corneal opacities, of cataract, of intraocular lens that is automated by the system, the detection of PCO, the detection of the risk for angle closure glaucoma, and so forth. You see that on the last page, we have AI-guided prescription for glasses and contact lenses, AI-based calculation of the intraocular lens, and also a probabilistic decision for the eligibility for both refractive surgery, cataract surgery, and keratoconus surgery. So if we go more into details on how we did that, you see here that the subject of predicting the subjective refraction based on objective parameter is not nearly new. We initiated this type of research in 2019 with our first published paper, but there are many other papers that refer to that approach. You see here that machine learning makes it possible to do a much better job than a conventional refractometer. When the refractometer is able to predict the correct refraction for the patient in 70% of cases, AI-based algorithms are able to raise this level to nearly 92%. We have the same approach for IOL calculation. In most calculation software today, only the intraocular, axial length and the keratometry are taken into account to predict the power of the lens. However, you see that if we use combinations of formulas that take into account more than just 2 parameters, that includes the white to white, the anterior chamber depth, the pupil size, and so forth, we are able to modulate the use of these formulas in a single machine learning algorithm, and therefore we can improve the prediction of the IOL to an accurate level of 0.12 diopters from 73%, that's what we obtained with SRCT in my last 5,000 eyes, to 93% when using this combination of formulas modulated by coefficients determined by machine learning. The last algorithm I want to describe is our decision-making tool for surgical indications in the intersegment surgery. We use 100 criteria. We apply 20 rules in an automated way to select the best possible of 17 surgical indications for each patient. You see here that we can manage quite in detail the cataract surgery management, phakic lens indications, laser surgery. We can choose automatically between PRK, LASIK, and SMILE. And also, we can manage keratoconus quite efficiently in an automated manner. The advantage of such an algorithm is that it calculates the necessary parameters much faster than the doctor, and it takes into account every detail about the patient that is related to the best possible indication in an objective way. The acceptance of the patient is surprisingly high. Patients liked our station. In Germany and the Netherlands, over 80% of the patients reported that they would like to have the same exam for the next routine exam the next year. This is a few clinical cases to demonstrate the power of this approach. This is, for instance, a case of clinical refractive surgery for high myope. The myopia is 7.5 diopters. And because the pachymetry is only 470 microns, logically, the system automatically recommends to offer an ICL surgery to this patient. The next case is also very interesting. It's an ophthalmologist, a colleague of mine. Her husband is an ophthalmologist, and she took the exam at the French Society meeting, and we were very surprised, both of us, to discover that the system recommended topo-guided PTK for her because the system had automatically detected a previously undiagnosed pellucid marginal degeneration in relation with her atopic dermatitis. So you see here that our algorithms are capable of not only doing a very advanced diagnostic for the patient, but also to offer for the best possible surgical technique, even sophisticated one for those patients. The last case is about the advantage of having this multimodal diagnostic approach for each patient. A lot of doctors ask us, why do you do all the exams to all the patients? And the answer is easy. It's because we want to make sure nothing is hidden. And you see here that this patient who was referred to me for keratoconus, she had seen 2 other doctors before. And you see that both of the doctors missed her cataract, subcapsular cataract, that you see clearly on the retroillumination image in the center of the slide. And also, they also missed the pigmentary retinopathy that affects her retina. So, in other words, when we try to benchmark our solution against other technologies that are available on the market for diagnostics, we see that we have definitely set a new standard, both for automation and the amount of exam we're able to complete in a very short amount of time. This will let us offer a much better medical service to our patients, a service that will be both high-end, accessible, and affordable for everyone to save time and save money for most of the stakeholders of eye health, including the patients, doctors, and insurers. We are now currently in the commercial phase where we're deploying our technology to different territories, both in Europe and Asia. And you are welcome to reach out to have more information about this. To conclude this presentation, I would like to say that the ability to streamline subjective and objective data with smartbots, robotics, and AI makes it now possible to meet all the requirements of advanced digital medicine, which means that we have approved medicine, which is practical, precise, predictive, preventive, personalized, and also participatory, since it allows the patient to appropriate their own health history and decisions. So I would like to thank all the people who have supported our effort to develop this technology. We were recognized for our effort, and we obtained in June this year the Innovation Award of the German Society, as well as other awards in the past. I would like to thank you very much for your attention and invite you to contact us if you want to have any demonstration of our technology online or on-site in Paris or in one of the other 20 sites that we have equipped so far. Thank you very much. Bye-bye.
Thank you very much, Michael, for this most interesting and important new technology that opens a new perspective in the clinical examination of our patients. Now, it's my pleasure to invite Arthur Cummins, dear friend from Ireland. He is going to talk about neuroadaptation, and it's a very interesting talk about how to have a fast track to stimulate neuroadaptation using bionics technology. Arthur, this is your time.
Hi, good evening, and many thanks for this kind invitation to the ARI meeting. My name is Arthur Cummins, and I'm going to be speaking about remote management of adult amblyopia. These are my financial disclosures, and the only one that has relevance is that of Binocs. We're all very familiar with amblyopia, a condition of reduced vision due to abnormal visual development, at least 300 million people affected, and the current standard of care is patching or penalization of the good eye, and treatment therapies in adults are ineffective. However, Binocs dioptic therapy has changed this. So when an eye is amblyopic, the brain receives only one dominant eye image, and dioptic therapy works differently to patching. When you patch the eye, the brain only receives the image on the suppressed eye. When you do dioptic therapy, you wear anaglyph glasses with one side blue or green, the other side red, and the image you're looking at is three-dimensional. The brain perceives both images, and the brain perceives both images as equal, given the fact that the good image is reduced in quality to match the amblyopic eye's image. So with two images now, you can have 3D vision. So does this work? I'm going to share with you a study involving 20 subjects, median age of 42, age 23 to 54 years of age, who showed improvements of 3 logMAR lines pre and post-op Binocs dioptic therapy, using the device for 30 minutes per day, 5 days a week, for 6 weeks. You can clearly see here the results of visual acuity in logMAR from pre-therapy to post-therapy. A Wilcoxon-signed rank test showed a statistically significant improvement in visual acuity of the amblyopic eye. The median visual acuity improved by 3 lines with a pre-therapy logMAR of 0.6 and it improved to 0.3. 11 out of 13 subjects developed stereopsis from no 3D to having 3D, and 7 out of 7 subjects who had stereopsis gained stereopsis from 100 seconds of arc to 50 seconds of arc. There are additional functions for dioptic therapy. It's specifically effective for anisometropic amblyopia, as you've seen, but additional applications are for so-called dry eye that is actually due to micro misalignment issues, neuropathic pain on occasion, binocular vision disorders, small phoreas and tropias, and then fast-tracking neuroadaptation, such as managing unhappy trifocal or EDOF patients. Binocs now has a global presence. It is based in Singapore, with most of the research being done in India. Some comments that were made after the ACOS meeting in Antwerp in 2022 is that this is probably the biggest and most exciting innovation in ophthalmology today, and adult amblyopes have gone from no hope to successful therapy within 6 weeks. It's a fast and significant permanent improvement in visual acuity, develops or restores 3D vision, and there is a collaborative strategic model involving reducing eye care practitioners' clinical burden while improving revenue streams by expanding the market. And Binocs is the thought leader in managing binocular vision in ophthalmology. The topic for today is about neuroadaptation in premium IOLs and how to fast track this. So we've all seen the patient who's 20/20 both eyes, J1, yet still unhappy. Complaining of poor contrast, halos, intermittent blurring of vision, shadows, rings, poor stereopsis. Let's look at the effects of a diffractive multifocal on the visual system. Well, firstly, it reduces visual contrast. It decreases binocular vision and depth perception. It may have positive dysphotopsia such as starbursts, rings, or halos. There may be negative dysphotopsia, and different areas in the field of vision are now in focus simultaneously, and the brain's got to choose between them, and the brain needs to focus on the area of interest and suppress the others that it's not interested in. The adult nervous system is remarkably plastic and has the ability to rapidly modify depending on the visual inputs. True neuroadaptation occurs from a few days to several weeks post-implant. It has the ability to rapidly modify depending on the visual inputs. Neuroadaptation mainly involves the hippocampus, and failed neuroadaptation leads to psychological adaptation and neuroresignation. It is a slow and complicated process, and 10% of patients may never adapt, and this is our major challenge with unhappy patients. There are three areas involved: the frontoparietal lobe, controlling the ability to judge size, shape, and distance attention; the cingulate cortex, associated with learning, emotions, and memory; and then the caudate nucleus is involved in adaptive behaviors, in planning and execution of strategies to attain complex goals. So the visual cortex is involved with the frontoparietal circuits, the cingulate, and the caudate nucleus. Attention comes from the frontoparietal circuits, initiation, motivation, cognition from the cingulate, and planning and execution from the caudate. If the neuroadaptation goes well, it's all green lights. You just neuroadjust. If it does not go well and there is failure of the process, then we lead to potential contribution of activation of the corticostriatal loops, leading to anger and frustration reflexively, meaning you can't help it. So failure to neuroadapt can lead to psychological problems. Training with binocs involves the dichoptic training, which the process involves the presentation of contrast-adjusted stimuli to each eye and the summation of both these stimuli. This improves contrast, spatial relations of binocular vision, but then also it involves perceptual and cognitive training on how our eyes interact with the environment and perform specific tasks. Training with binocs for visual performance for unhappy patients with diffractive multifocals occurs in the comfort of your own home, on your own laptop or computer, 30 minutes a day, 5 days a week, and is normally completed within 2 weeks. These two case reports show what can be done. A patient with 8 diopters of exophoria, 400 seconds of arc for near and absent for distance, unhappy with the result. Following binocs therapy, no need for IOL explantation. Patient is happy, stable images, clearer visual perception, and less glare. A second case with dense suppression in the left eye, poor lack of visual acuity, lack of depth perception. And after 10 sessions, normal binocular vision and visual acuity, 20/20 in both eyes, 150 seconds of arc stereopsis present, and a happy patient. A significant improvement in low contrast visual acuity is reported. So binocs has a big application across ophthalmology, across all of these, and in this regard, it's a valuable tool. Many thanks for your attention.
Buenas, continuamos con los avances. Como habéis visto, la sesión viene interesante y cargada de grandes novedades. Y ahora vamos a hablar de un tema completamente diferente, pero que también resulta muy interesante, como son los sistemas de aberrometría de campo abierto, aplicaciones a la práctica clínica, que nos la va a dar Antonio Martínez Abad, que trabaja aquí en Miranza, Alicante. Adelante, Antonio.
Buenas tardes a todos. A lo largo de la presentación voy a hablar acerca de la aberrometría de campo abierto y sus principales aplicaciones clínicas. Decir que no tengo ningún tipo de conflicto de interés comercial con el equipo principal del que voy a hablar. Como todos sabemos, los aberrómetros oculares permiten caracterizar las imperfecciones ópticas del sistema visual, siendo crucial su medida en el diagnóstico y manejo de multitud de patologías oculares, así como también a la hora de evaluar el rendimiento óptico proporcionado por las nuevas lentes intraoculares. Estas aberraciones pueden describirse mediante la aberración de rayo, la diferencia de camino óptico o lo más empleado a nivel clínico, que es mediante el frente de onda ocular. Aquí podemos ver en la primera imagen el mapa de frente de onda, donde vemos la distribución en todo el diámetro pupilar de estas imperfecciones visuales. De este frente de onda precisamente se derivan los polinomios de Zernike, que son los que solemos emplear a nivel clínico para interpretar cada caso. Los aberrómetros comerciales pueden ser de diversos tipos, desde los basados en tecnología Harman-Sack, que emplean un sensor Harman-Sack para evaluar la luz reflejada por la retina, por lo tanto son de frente de onda emergente. Por otra parte, tenemos los basados en trazado de rayo y recientemente ha surgido la tecnología piramidal, que emplea un sensor de tipo piramidal para dividir la luz en 4 secciones y de este modo poder obtener unos resultados a priori más precisos. Las aplicaciones de estos aberrómetros son múltiples, desde la obtención de la refracción objetiva, gracias al análisis de las aberraciones de segundo orden, al diagnóstico y manejo de multitud de patologías, sobre todo las patologías corneales, así como también son indispensables para los tratamientos láser customizados, así como son de gran relevancia en las lentes intraoculares o cirugía de cristalino, sobre todo para analizar el rendimiento óptico proporcionado por las mismas. Por último, también son de gran utilidad en el diseño y en el avance científico de nuevos diseños ópticos, ya sea de lentes intraoculares, lentes de contacto, etc. No obstante, estos aberrómetros tienen limitaciones, donde destaca el requerimiento de una superficie lagrimal perfecta, así como también de unos medios oculares sanos para poder reconstruir todo el patrón aberrométrico y obtener resultados precisos. También destacar que es muy dependiente del tamaño pupilar y requiere una iluminación totalmente escotópica, así como un centrado completamente perfecto donde el paciente debe de mirar al centro del estímulo para una correcta reconstrucción. La gran mayoría además de los aberrómetros comerciales miden de forma monocular y son de campo cerrado, por lo que hay una implicación de la acomodación en la medida. Con el fin de solventar estas limitaciones, ha surgido el aberrómetro de campo abierto OFA Osiris, desarrollado por la casa CSO, que nos permite trabajar en espacio real con todas las ventajas e implicaciones que tiene. Por una parte, que podemos customizar el estímulo, ya que al trabajar en espacio real podemos poner el estímulo que queramos, algo útil en niños o en gente de baja colaboración. Además, el hecho de trabajar en espacio real implica que no se involucra la acomodación y por lo tanto tampoco la emergencia. Además, este modelo concreto utiliza tecnología piramidal y la medida es muy rápida y sencilla. Aquí podemos ver imágenes del equipo y del procedimiento de medida. Como hemos dicho, la medida es muy sencilla. El paciente debe de poner su cabeza en la mentonera y debe de fijar a través de un espejo semi-inclinado, mirando al infinito, a través de un punto rojo que nos marca la dirección de mirada y que se solapará con el objeto de fijación. Es entonces cuando el examinador alinea el centro óptico del equipo con el centro del diámetro pupilar y tras pulsar el botón en un par de segundos la medida es muy rápida. Con el fin de validar los resultados proporcionados por el equipo, hemos hecho diversas investigaciones. La primera de ellas busca comparar los resultados de refracción objetiva proporcionados por el campo abierto frente a los proporcionados por el campo cerrado y también frente a la refracción subjetiva. Para ello, analizamos 35 ojos sanos que no presentaran patologías oculares ni disfunciones en la acomodación. Es entonces cuando el examinador realizó las 3 medidas de refracción y comparamos los resultados mediante la t-Student considerando una significación estadística de 0,05. Los resultados obtenidos fueron los siguientes. En primer lugar, al comparar la refracción subjetiva con los proporcionados por el aberrómetro de campo cerrado, pudimos ver que existían diferencias estadísticamente significativas, siendo valores más negativos de en torno a media dioptría con el aberrómetro, debido probablemente a la acomodación tónica por el hecho de tener el aparato a una distancia próxima de los ojos. Sin embargo, cuando comparamos la refracción subjetiva con la aberrometría de campo abierto, pudimos ver que no habían diferencias significativas, siendo unos resultados más precisos. Por lo tanto, las aplicaciones clínicas que se derivan de este aberrómetro de campo abierto son, por una parte, la mejora en los resultados de refracción objetiva. En segundo lugar, y como consecuencia de una mejora de la precisión de los resultados, también se tratará de un mejor método para evaluar las aberraciones oculares y los tratamientos láser customizados. Además, el equipo nos permite medir la refracción periférica, ya que gracias a trabajar en espacio real, podemos instruir al sujeto a fijar un objeto periférico, de modo que cambiamos la dirección visual de mirada y podemos medir la refracción en esa sección concreta que deseamos. Esto puede ser muy útil de cara a evaluar la refracción en determinadas enfermedades que cursan con afectación de la periferia, así como también para un mejor entendimiento en el proceso de metropización y en los mecanismos de control de miopía basados en desenfoque periférico. Además, podemos medir la acomodación. ¿Y esto cómo lo hacemos? Tendríamos que hacer dos medidas. En primer lugar, una medida estándar en visión lejana y por otra parte deberemos de ubicar un texto a una distancia próxima a la distancia deseada y volver a realizar la medida. Realizando la diferencia entre ambas, obtendremos la acomodación a la demanda acomodativa deseada. Por último, se trata de una herramienta con gran aplicabilidad en el campo de las lentes intraoculares, ya que al no tener un estímulo cercano, un estímulo acomodativo, tampoco habrá una estimulación vergencial y esto cabe esperar que el centrado sea más fino y por lo tanto los resultados puedan ser más precisos. Además, el diámetro pupilar va a ser más realista, ya que, dado que no tenemos el estímulo cercano, esto va a generar que no haya una afectación de la dinámica pupilar y los resultados van a ser más realistas sin inducir la miosis propia del campo cerrado. Por último, es especialmente útil en las lentes intraoculares acomodativas, ya que, al igual que en pacientes con buena capacidad de acomodación, cabe esperar que los resultados sean más precisos. Aquí se muestra un ejemplo donde la esfera obtenida mediante refracción subjetiva es idéntica a la obtenida con el campo abierto, mientras que con el campo cerrado el valor fue considerablemente más negativo. Por lo tanto, a modo de resumen y como conclusiones, destacar, en primer lugar, que se trata de un nuevo y un mejor método para obtener la refracción objetiva. En segundo lugar, y asociado a ello, que también es un mejor método para obtener las aberraciones oculares y por lo tanto para plantear tratamientos customizados. En tercer lugar, que es un equipo que nos permite medir la refracción periférica con las implicaciones que puede tener. En cuarto lugar, es un método capaz de medir la función acomodativa de una forma totalmente objetiva. Y por último, que se trata de un paso más en el entendimiento y en el uso de las lentes intraoculares premium, especialmente las lentes acomodativas. Esto es todo, muchas gracias por la atención y quedo a disposición de sus preguntas en el debate.
Muchas gracias, Tony. Magnífica presentación de una nueva tecnología que va a ser muy importante en el desarrollo de las lentes acomodativas. Pasamos ahora a una interesante charla sobre la angio-OCT de segmento anterior en el diagnóstico y evaluación de las lentes de contacto, a cargo de Javier Cantó. Tienes la palabra.
Hello and good afternoon. Firstly, I would like to thank the organizing committee of the Congress. Today I am presenting in English, but as this is not my first language, I would like to say in advance that I may make a few mistakes. I intend to talk about the OCT angio technology, but when it is used in the anterior segment. I will discuss the clinical application that exists up until now and the possible advance in the field of optometry. The intervention I present has not been financed totally or partially by any company with economic interest in the products, equipment or similar cited in it. So, how is this possible to obtain angio-OCT? OCT angio is obtained by a series of switches with high precision over and over again in the same zone between 3 and 6. So in the end, the software detects and enhances what in that time interval has undergone changes within the tissues. This takes approximately between 5 and 30 seconds. Once the capture is complete, a detailed analysis of all vascular structures is performed. The team then reconstructs point-to-point structures, differentially the superior plexus, Now I show in the image. The deep plexus, the outer retina plexus, and the choriocapillary vascular plexus. Finally, we have a color map that when together represent the vascularization of the retinal layers. But the software that we use in this technique is prepared to examine the posterior segment and not the anterior segment. That is why it is necessary to have some experience in using this instrument to be able to obtain quality image. If you use the Triton OCT, we don't have to use the special lens to examine the anterior segment. Indeed, you have to use a support for the forehead and use the plus auxiliar lens. There are different studies that have been based on OCT angiography as a technique. For example, to identify areas where there is less vascular framework and therefore administer intravitreal injection in this area. Then we can avoid conjunctival hemorrhage. Another study proved that with this technique we can control the vessels and the growth of the nevus that appears in the anterior segment. Other studies relate this technique for the control of neovascularization in contact lens wearers. Here we have an image where we can see perfectly the neovascularization. It is another example, the neovascularization in one wearer of contact lens. Other studies relate these techniques with the control of corneal transplants. You can control the possible changes as a result of the transplant, such as neovascularization. With this technique, it is possible to control the structural changes that are generated in an anterior uveitis. Well, but we can try to use this technique in the field of the optometry. We have developed a scale based on the conjunctival vascular clearance but observing the angio-OCT in the anterior segment. We can predict the change that we will have to be made to the SLZ curve of the scleral lens. On the slide below, we can see angio-OCT without contact lens. We can see the normal distribution of the vessels in this patient. On the center of the slide, we have a patient with a scleral contact lens. We can see the indentation caused by the lens, and there appears to be a blockage to the conjunctival vessels, which creates a clear zone to the conjunctiva that we can see and compare in the normal image. We put two different grades that it is relation with the changes of the SLZ curves. In the image of the top, we have the same patient with more indentation scleral contact lens. This is causing more blockage to the conjunctival vessels. If we change the angle of the SL zone curve, can alter the indentation. In this case, we have changed 5 grades of the SLZ curves. If we compare the indentation in the nasal, superior, inferior, and temporal zone, we can do a special scale to adapt perfectly the scleral contact lens. OCT, anterior segment angiography, is a new technique that is in the process of being developed. This process allows us to get much more information and provide our patient with better optical care. As you can see from the presentation, it covers a wide spectrum of possibilities, from pathological alteration to application in the world of contactology. That is why I encourage everyone to get involved in this technique, as in my personal opinion, it will be a reference in the future for the continuous care of our patients. Thank you for your attention, and I hope that everybody has benefited from and enjoyed this Congress.
Well, thank you very much. Fascinating technology, fascinating technology. We want to invite now our panel for discussion, and it will be Mario Cantó Cerdán, Noa Molina, Alberto López Miguel, and Miguel Maldonado from Valladolid. So welcome to this debate. And Miguel, you have been obviously many years leading IOBA and with the technology that is emerging in the last years. What do you think about these new topics, especially artificial intelligence and the emerging value of diagnostic imaging techniques?
I believe that they can be of a great value in the present and near future. However, I have some concerns about some ethics, with respect to data. I don't know to what extent data can be confined to the ophthalmic office, and some challenges about managing data about patients are of concern in the modern medicine. So I really admire the system that has been presented this afternoon here, but I have some concerns about sharing information and if this information comes out of the office, the ophthalmic office, where this data could end up being. That's a concern I have personally.
Michael, do you have feedback from patients and doctors of the recently installed devices that you have in Europe?
Not particularly, but I strongly believe that the system that has been presented today has a great potential. But I have a question if this system could be more valuable in areas in which there isn't a good ophthalmic coverage, or can be something that could be managed by people that are by the ophthalmologists trying to reach more patients, and this way widening the scope of ophthalmic care to patients. That's something that is interested to be pointed out. And I don't know if the presenter is ready to speak this afternoon.
Okay, I would like to ask about open field aberrometry to Tony. You are stating that these systems can be very useful in the field of myopia control. Do you think that you can measure probably in the future with these systems in a very accurate way the peripheral defocus in a way that we can customize myopia control optic devices? or you can select the type of peripheral defocus that you generate with the contact lens or the ophthalmic lens?
Yes, of course, it is a very relevant issue for is comment along all the cars today, and it is not the main purpose or the main objective of the device, but obviously it may be an impact in short term, and as I have commented previously, we can measure this refraction. But the problem now, we are experimenting in some patients, but the problem is that we have to select the procedure very good because the angle conditionate a lot this measurement. But we have tested in some patients, and obviously the refraction, the peripheral refraction when we turn the main direction involves in the refraction, and it can be very relevant not only in children for optical mechanisms in the myopia control, but also in patients operated by laser in the post myopic laser in adults. Okay, to see if this peripheral defocus generated by the ablation it's related with slow increase even in adults in high myop adults. We are investigating about that, but obviously in a future, not yet.
Thank you very much. And Arthur, about neuroadaptation is really a great topic, you know. And my question to you, you have treated adults with this technology. Have you tested how long it lasts, or is the results are permanent? Because this is the main question, whether there's a possibility to regress the positive effects that obviously is obtained. What is your experience about the long-term results?
Yeah, that's a really good question, Jorge. So we haven't got a huge amount of patients, but those that we've treated seem to retain what they've learned. I asked the same question of Bionox, and they have follow-up over many, many years, and they find that once you've established stereopsis and you've established improvement in the amblyopic eye, that you retain that. So what they did, because I'm on the advisory board, what they did to make sure people get that message is, once you've had a treatment done, is there's a free treatment again in the future if you ever were to need it. But so far, no one has.
Good, very good.
I have one question for Arthur. Hello, Arthur. I would like to ask you to you, or if you want to say something also, Mario or Ainhoa, is about what is the role also of binocular problems on the failure to the adaptation to the multifocality, because you have shown two cases, very interesting cases. What is your experience?
There's so many things. The person in my experience who has really studied this well is Rohit Shetty from India. And he's looked at so many facets that we blame on dry eye or other conditions, where in fact, all that's the problem is this small misalignment in the optics. And I think one of the things that happens when we go from spectacles to no longer requiring spectacles like you do with the multifocal is, even though your spectacles have never had a prism, is they might have had a prismatic effect, depending on the center of the lens, the pupillary distance, and this kind of thing. So I think there are many things that are beyond my understanding that become apparent once the spectacles are gone, and you now have to adapt a new alignment. And in these cases, the small adjustment in alignment, improving binocularity, and therefore correcting small phoreas and tropias, delivers a better functionality and success. But I'd love to hear your other comments too, David. You know more about this than all of us.
Thank you. Michael is there. And my question to you is, this is a remarkable technology and opens the key immense area of application. So do you have feedback from patients and doctors that have been using the technology about the precision and the increase in the flow of patients that they have by using this technology in their clinics? Michael, we cannot hear you.
Please activate the sound. Okay, thank you.
I don't know if you asked me, but I have problem because the communication is cut.
Can you hear me now? Yeah. So
I can listen.
The first question is about the precision. Can you hear me?
Yes.
Sorry.
Yes.
Yeah. So we've done plenty of retrospective studies to ascertain that the outcome of the measurements and the prediction we do are on par with the current technologies that most doctors are using, or even better, especially for IOL calculation and the prediction of subjective refraction. Now, in terms of opening new ways to practice ophthalmology, it has changed my personal practice myself by the fact that I get much more data about different things for a single patient that I used to have before. Especially, I found quite interesting for an anterior segment surgeon to have imaging of the posterior segment that makes let you make sure that nothing is hidden in the case. And also, I make a very good use now of the epithelial maps, the retroillumination image. Some data that we didn't use to have on a routine basis for our patients, and makes it much easier to assess a number of conditions in the cornea and the anterior segment as well. So I think the key here is to understand this new concept of multimodal imaging obtained instantly. And the combination of the two things makes it much easier for the doctor.
Okay. Thank you very much, and thank you all of you for your time and your talent in the presentation, the debate. And we need to close the session because we are out of time. I want to thank all of you, Felix, Arthur, Tony, Asulin, because you have been great in this session, and I hope that the future will open new opportunities for our patients using this technology. Thank you very much, and the session is closed.
Thank you so much. Great session.